So thank you very much, Bronwyn, for inviting me. Thank you very much, Linda, for helping me. It's really, really nice to have been invited. And I've been helped a little in constructing this talk by members from your society, and I've got the questions that have been raised listed here, and I might just read them out, and through the course of the talk you might be able to identify where each of them have been answered, and if they haven't, you can raise a question later on. So in turn, how is immunotherapy-related adrenal insufficiency different to Addison's disease? Should I be screened for vitamin B12 deficiency if I have Addison's disease? A whole heap of questions on stress dosing. So what signs tell me to updose? How is stress dosing with prednisone different to hydrocortisone? Can Cortef be given subcutaneously rather than intramuscularly? How should the emergency kit be stored? Do other people have trouble with steroid-induced low blood potassium? What developments have there been in cortisol pumps? And someone who's had marked tachycardia, so fast heart rate following local anaesthetic with adrenaline for a dental procedure. And the question, is this related to my adrenal insufficiency? So from those questions, I have ordered the talk to deal with four main themes. So number one, what are the causes of adrenal insufficiency? Number two, what associations does adrenal insufficiency have with other autoimmunity? And thirdly, how should I be screening for this other autoimmunity? And then finally, a section which probably represents about half of the 20 minutes I have on sick day signs and management. So causes of adrenal insufficiency. I understand that not everybody in the AADAI has Addison's disease. There are some others who've got central adrenal insufficiency and perhaps some other forms of primary adrenal insufficiency. So we break the forms up into central and primary. Central refers to either hypothalamic or pituitary adrenal insufficiency. And how does that affect the adrenal glands? Well, it's through ACTH, the adrenocorticotrophin hormone that normally talks to the adrenal to tell it to get up on the horse and squirt out a bit more steroid hormone that is lacking. And all sorts of causes, drugs. So, for example, excess glucocorticoids, perhaps in the context of other illness, such as rheumatological illness, other medications, including opioids. So those are pain relief medications, can suppress the hypothalamic pituitary adrenal axis. Hypophysitis, and I have been advised that there are a number of people who've got immune checkpoint inhibitor-induced hypophysitis listening in today. I'm presuming CTLA-4, but perhaps other forms. Hypophysitis can also occur in the context of pregnancy and other conditions. Trauma can cause ACTH insufficiency. There's also pregnancy-related hemorrhage, which is very rare, but it causes infarction of the pituitary or hypothalamus and means that the pituitary is unable to make the right hormones or the right amount of the right hormones. Tumours can do it, and most commonly that would be pituitary adenoma or craniopharyngioma, but there's a whole host of others. And in my after cancer care clinic, I have a number of people who've got radiation-induced hypopituitarism, so with significant doses of radiation, all of the pituitary hormones can be knocked off potentially. Then moving to causes of primary adrenal insufficiency. So similarly, there are drugs, and mitotane is the main one. Congenital adrenal hyperplasia, and it depends on how much enzyme there is functioning as to how severe the adrenal loss might be or the cortisol loss might be in that condition. Autoimmune, which is another name for Addison's disease. For 21-hydroxylase antibody negative males, adrenoleukodystrophy should be considered. That's where there's elevation in very low chain fatty acids. And then finally, there are structural causes to the adrenal gland, so adrenal hemorrhage, infiltrative disease, malignant tumours, and infection, and all of these have got an abnormal CT scan. So moving on now to associations with other autoimmunity, it's super common. So more than half of people who've got Addison's disease have got some other form of autoimmunity, sometimes many other forms. Whereas if you take the flip perspective, so looking at the more common autoimmune disorders, type 1 diabetes and thyroid dysfunction, very rarely are they complicated by adrenal insufficiency. And polyglandular syndrome type 2 describes the condition which is defined by adrenal insufficiency plus either autoimmune thyroid disease or type 1 diabetes. But you can see that there are other endocrine as well as non-endocrine conditions that are characterised by that condition. And this has onset mostly between 20 and 40 years of age, and it can have many different types of inheritance. So it could be from one parent, it could require both parents, or it could be many, many genes that contribute to someone developing that. Less commonly is the polyglandular syndrome type 1. I'll just mention it very quickly because that's where there is commonly Addison's disease and other autoimmunity. That one is diagnosed at birth. And this slide just shows, the more common types of autoimmunity, and the age of onset is on the y-axis. You can see that whilst some conditions such as type 1 diabetes are diagnosed generally at a younger age, and conditions like rheumatoid arthritis are diagnosed at an older age, there's a wide spectrum of age of onset for all of these conditions. So essentially you can have autoimmunity popping up at any age. And there doesn't seem to be really consensus on what should be done in terms of screening. So this is the guideline that was put out in 2016 by the Endocrine Society in the US, and they suggest that the optimal frequency for screening, it's not really known, but could be considered annually. And the conditions that might be screened for would include thyroid disease, celiac disease, diabetes, premature ovarian failure, and autoimmune gastritis causing vitamin B12 deficiency. And just quickly, how would you go about having these conditions screened for? Well, firstly, why would you screen? Developing other autoimmunity may be clinically silent, so it may not be like Addison's disease where you feel really terrible and you know that there is something wrong. So it can actually present without any symptoms, but there may be consequences from not having it diagnosed. Screening for thyroid dysfunction, I'd be suggesting anti-TPO antibodies. That tells you if there's thyroid autoimmunity, and then if there is, then TSH could be checked. It's a fairly cheap and easy test to do, just a blood test. With type 1 diabetes, there's actually been a change in the way that can be screened for. The majority of people with type 1 diabetes have already got antibodies that are positive by 3 years of age. So if someone has Addison's disease and wants to be screened, I would be suggesting a once-off antibody check. And if that one's positive, then HbA1cs could be done, which is a surrogate marker for glucose levels, could be done every year. With premature ovarian insufficiency, obviously only affecting women, if there is irregular menstrual periods, then FSH and AMH can be checked. With celiac disease, there are antibodies that if they're 3 times the upper limit of normal, a biopsy through a gastroenterologist would be indicated. Gastritis is its other name is pernicious anemia. So this is where there is loss of the parietal cells in the stomach and B12 can't be absorbed. That one could be screened annually with a full blood count and B12 levels, and consider active B12, which might be a better test. And this one can be supplemented with injections. I might just add, for B12 insufficiency in the vegan cohort of people, oral B12 can be used, but if someone's got autoimmune B12 insufficiency, then oral B12 won't be absorbable, so it needs to be given through a different route. And screening really should be continued throughout life, as there's no maximal age cut off for identifying additional autoimmune disease. If you've got Addison's disease, then family members might consider having screening done. And it's a bit tricky. If they have symptoms, then they might choose to have an early morning cortisol, but there's a really wide range of normal. So if the symptoms are really marked, then I'd be suggesting a short synapthin test, plus or minus an ACTH level, to diagnose the condition. So how am I going for time? I should be at the halfway mark. So stress is something that everyone experiences, with or without adrenal disease, and it's a normal part of life. We all have different ways of dealing with it, so our experiences feed into how we might behave in response to stressful situations. But I'm going to be talking not so much about those cognitive aspects of managing stress, but rather the neural and hormonal aspects. And I've got a little cartoon here, and I'm going to ask you to read it rather backwards, so from the right to the left, because the LC-NE refers to noradrenaline. So that's where the nerves in the sympathetic nervous system is activated. There's very, very rapid response in terms of speeding up of heart rate and a drop of blood pressure, or in some vessels, a squeezing of blood vessels. The point is that that's the early response, and then the slightly later response would be the hormonal one. So the sympathetic nervous system, you can see there is a connection there to the adrenal gland down the bottom. And yes, the adrenal gland acts as part of the sympathetic nervous system. But then there's communications from the hypothalamus and the pituitary that tell the adrenal gland to help raise a stress response hormonally, and that one is more sustained. It's got widespread physiological changes. Now, adrenal crisis, the biggest worry faced by someone with adrenal crisis is hypotension, because there can be failure in terms of the heart's response to a drop in blood pressure. Now, importantly, hypotension is mostly due to mineralocorticoid deficiency, so not glucocorticoid, which is the other hormone that comes from the adrenal gland and which is lost in Addison's disease. And those people who've got central adrenal insufficiency, generally they have adequate mineralocorticoid. So it would be much less common to have a severe drop of blood pressure in someone who's got a secondary adrenal or central adrenal insufficiency. There is a contribution, however, to hypotension by glucocorticoid deficiency, and this is sort of by indirect means, through glucocorticoids decreasing the synthesis of renin, which is a substrate for the mineralocorticoid hormones. Glucocorticoid can also reduce responsiveness of blood vessels to vasoconstrictive hormones and can increase the production and action of vasodilatory hormones. In all types of adrenal insufficiency, these other signs of glucocorticoid insufficiency may be present. So hopefully they're all familiar to you: anorexia, nausea, vomiting, abdominal pain, weakness, fatigue, lethargy. Fever can be exaggerated by low cortisol, and hopefully no one's experienced such severe deficiency as would result in coma. Sometimes people who've got central adrenal insufficiency can have a low glucose level, and it could be that that's partly because of other hormones that are lost when the pituitary is impacted. And this is actually only something that's really been reported on in the last decade or so, is that whilst adrenal insufficiency really describes the loss of hormones from the adrenal cortex, there is also a part of the adrenal glands called the adrenal medulla that's responsible for making adrenaline, and glucocorticoid deficiency can have an impact on adrenaline production. So there is usually a compensatory increase in noradrenaline, but I would be expecting that would result in less tachycardia in the context of adrenal insufficiency. So I'm not sure that it would necessarily explain the members' experience in the context of dental surgery, where adrenaline injected resulted in a really rapid heart rate. So I find that difficult to attribute to hormones. It could be that there's a sympathetic nervous system response. I certainly have a sympathetic nervous system response when someone sticks needles into my gums, or it could be that the adrenaline was injected into a blood vessel potentially. Now, one of the other questions was, do other people have trouble with steroid-induced low potassium? And this is an interesting question. So being an endocrinologist, I see all sorts of conditions, and it includes conditions of cortisol excess. So Cushing's syndrome. And in Cushing's syndrome, we do see a drop in blood potassium, otherwise known as hypokalemia. And the mechanism that occurs through is cortisol. It's normally inactivated through an enzyme called 11-beta hydroxysteroid dehydrogenase into cortisone that does absolutely nothing at the mineralocorticoid receptor. But if you've got too much, then that enzyme is swamped. Cortisol can't be inactivated, and you have cortisol activating the mineralocorticoid receptor. So the response can be low potassium. However, I would be suggesting whilst with high dose prednisone or hydrocortisone, there can be an increase in urinary potassium excretion. This really wouldn't be enough to cause a really substantial drop in blood potassium, and I'd be looking for another cause of low blood potassium, of which there are many. Now, on your members' website, I found this article. So all of you have got access to this, and it's excellent. So it talks about Addison's disease and how to manage sick days to avoid crises. And quite a few helpful tables. You can see some here. One is an example of sick day management plan to be provided to patients. So hopefully you've all got one of these. So a written sick day plan. Generally, what I say to my patients is, if they're unwell, they should have a doubling of their usual glucocorticoid. If they're very unwell and bedbound, they should have a tripling. And if they're vomiting and unable to take oral medication, they should have an injection and then go straight to hospital. And you can see down below, there's a number of glucocorticoids listed there. A milligram of one doesn't correspond to a milligram of another. I should also add, if someone's on a very, very high dose of glucocorticoid, so higher than prednisone 5 or hydrocortisone 20, you may need less than what I was suggesting just earlier. But you'd be asking your healthcare professional for that information. And the other important thing, hopefully you've gleaned from what I said earlier about mineralocorticoids, it's very, very important to have mineralocorticoids on board to prevent hypotension if you've got Addison's disease. And you can see that not all glucocorticoids have got the same proportion of mineralocorticoids. So whereas hydrocortisone got a fair bit, prednisone has much, much less. And if you're on prednisone, it could well be that you need fludrocortisone on board. So simply stress dosing with prednisone might not be adequate. I should also add that if you've got enough on board outside of sick days in terms of mineralocorticoid, then you'll be fine for sick days as well. You just need something on board. And this last table is just a presentation of the kind of doses of hydrocortisone that your healthcare professional might be prescribing if you're having surgery. The point being that you need more, and depends on how big the surgery is as to whether you need a lot more. Now, someone asked about the emergency kit, and specifically what they asked was with regards storage of it, can you keep the emergency kit in the car? And I put this to my pharmacy and they said there isn't an emergency kit. I can see that your organisation might provide something along these lines. Pfizer also provides a carry case, but your healthcare professional needs to give you the contents of it. So the Woolloongabba, the alcohol wipes, and yada yada means by which to inject it. And the Woolloongabba is the only thing I'm aware that needs to be stored with care. So it must be kept below 25 degrees, protected from light, and shouldn't be used past the expiry date. Some other components also have expiry dates. But in general, anything kept in the car is going to get above 25 degrees. So yes, I wouldn't be recommending that. This is just a note. If anyone wants one of those Pfizer carry cases, they can be acquired. And there's a phone number that you can text if you wanted to get hold of one. Now, hopefully everyone with adrenal insufficiency has been provided with their emergency Woolloongabba and has been given instruction on how to administer it. This shows it being given intramuscularly. Now, I was asked a question, is subcutaneous hydrocortisone an option for stress dosing? And there has been a publication a bit over 10 years ago looking at this for emergency use, so where 100 milligrams was given in 2 separate doses, so 50 and 50 given at different sites. And it was found that in emergency situations, so presumably in crisis, a similar peak of cortisol was reached. However, the time to peak was significantly slower, so 22 minutes subcutaneously compared with 11 minutes intramuscularly. And these delays might be longer if someone's carrying a bit of extra weight. So in conclusion, subcutaneous hydrocortisone is not suitable for emergency use due to poor absorption in active shock. There's another publication also a while back for routine stress dosing with subcutaneous hydrocortisone. And yes, it's listed as an option, although I think in Australia it hasn't been approved. So take that advice with care. Someone asked about hydrocortisone pumps, and yes, I'm aware that there's quite a few people out there using hydrocortisone pumps in Australia and elsewhere. At this stage, they haven't been approved, and this is just a little blurb from so the stakeholder comments from conversations in the UK last year, remarking that it can be useful for certain individuals, particularly those people who've got difficulty with absorption due to gastrointestinal problems, but it's expensive and can be sometimes tricky to use, and hence isn't recommended for widespread use. Oh, and that's the end of my talk. So